Just a little review, respiratory concepts that are going to be important when we begin class coming up this week. So just a few things to sort of refresh your memory on as far as some concepts that are important when you're talking about patients who are going to be caring for in the critical care environment, especially those patients with respiratory failure. Patients are going to have respiratory failure and require ventilation, mechanical ventilation for a variety of reasons. Specifically, we're going to talk about respiratory failure in a bunch of different disease processes. So we're going to review the patho a little bit on those diseases just to dust off that memory. But ventilation is essentially inspiration and expiration. It's important because it's the reason why we have respiration, really. It's to promote gas exchange, right? We breathe in air in the hopes that we can exchange oxygen for CO2. Inspiration, the movement of air into the lungs; expiration, the movement of air out, occurs essentially because there's a change in intrathoracic pressure in relation to the pressure at the opening of the airway, so the pressure that's in the environment. Inspiration, air is actually going to move from this higher atmospheric pressure, which is outside the body, to a lower intrathoracic pressure in the lungs. That's an increase in negative pressure. So we draw air in under negative pressure when we breathe normally. This is going to be important when you cover mechanical ventilation because normal, natural breathing is negative pressure. Mechanical ventilation, when patients stop breathing or they're sedated and they can't take those natural breaths and we have to breathe for the patient through a mechanical ventilator, we do that through positive pressure. So again, normally we draw in air under negative pressure, but when we have to mechanically ventilate a patient, it's positive pressure ventilation. We have to actually push air into the patient's lungs in order to inflate those lungs. And so that's just it's a different mechanism, but it becomes important because of the changes in the intrathoracic pressure in the patient. When patients are dyspneic and breathing fast, they cannot usually take that deep breath, so they may not be able to create enough negative pressure. Therefore, they'll take in a smaller tidal volume of air, is one of the reasons why patients can have respiratory failure or have hypoxemia, again, because they just cannot take those deep breaths. Expiration is usually a passive thing. It usually occurs when there's elastic recoil of the chest. Lungs tend to have a tendency to recoil and reduce volume when they're stretched. So lung tissue is full of something called elastic fibers or elastin. And so as they recoil, intrathoracic pressure increases and essentially forces air out. Compliance is really important because compliance is actually the ability of the lungs to take in air and then recoil. Compliance can be decreased where lungs can't actually expand, so that's really when there's a decrease in compliance, usually because there's some condition inside the lung that makes the lung tissue less elastic, such as pulmonary fibrosis, or any condition that restricts lung movement. That's stiff lungs usually have to do with a decrease in compliance. Compliance can be increased, on the other hand, when there's destruction of the alveoli. So when you have alveoli that are already overdistended, it makes it very easy to put air in, but there's loss of tissue elasticity. They're overinflated, so lung compliance is actually increased. Compliance is really important, or going to become very important for you guys when you are talking about mechanical ventilation next week, because based on the patient's lung compliance, we have to manipulate the ventilator so that we don't overdistend the lungs, or that we monitor when there's increased pressures within the airway. Lung compliance is going to become an important concept then. Respiratory control is under control of the respiratory center. There in the brainstem medulla, there is actually a respiratory center that responds to both chemical and mechanical signals. There are chemoreceptors that are found in the medulla. If you remember, those chemoreceptors are important because they respond to changes in pH, or hydrogen ion, and PCO2 as well. So those chemoreceptors are important because if the environment is acidic, so if there's an increase in hydrogen ion, it's going to cause the medulla to increase the respiratory rate and tidal volume to try and blow off some of that increased CO2. if there is a decrease in hydrogen ion or you have an alkalotic environment, you're going to have the opposite effect. There's also chemoreceptors that are found at the base of the common carotid arteries and at the aortic arch. Those are important because they respond to decreases in PaO2. So when your patient's hypoxic, the blood that's coming out of the left ventricle, if that blood is not fully oxygenated, those chemoreceptors that are right there at the aortic arch are going to sense that right away, and that is why they will also signal the brainstem then to, at times of hypoxia, to go ahead and increase respiratory rate to sort of ward off some of that hypoxia. Your body doesn't know to do any different. It may not actually have the right result, but that's what's going to happen just in response to the chemoreceptor signaling that respiratory center. There's also mechanical receptors located in the lungs, the upper airways, the chest wall, and specifically the diaphragm. Those are important because they're stimulated by things such as stress and irritation. So as we are taking that deep breath in, as the lungs are inflating, those pulmonary stretch receptors are actually activating the respiratory center to inhibit further lung expansion. It's what sort of helps us prevent over distending our lungs. And so when those stretch receptors are sensed or stretched, the impulses then are going to travel back to the brain via the vagus nerve, and they're going to turn off the inspiratory effort, and then our lungs will naturally be full enough, and then we will have elastic recoil occur, and expiration or exhalation will occur. Respiration itself is actually the exchange of oxygen and carbon dioxide. Remember that those things move across alveolar capillary membranes by the diffusion. It's important because oxygen moves from an area of higher concentration, such as the atmosphere, into the arterial blood, and then CO2 moves from the arterial blood into the alveoli gas, and we go ahead and exhale the CO2. Diffusion will continue until equilibrium is met. The ability of the lungs to oxygenate arterial blood is determined both by the PaO2 and the SaO2. The partial pressure of oxygen in arterial blood is what is known as your PaO2. This is actually the amount of oxygen that's dissolved in the plasma. It's expressed as an actual number in millimeters of mercury. This is the number you're most concerned about when you're looking at hypoxia. This is measured on an arterial blood gas. The O2 sat, or the SaO2, is really just your arterial oxygen content. All the SaO2 is the amount of oxygen that the hemoglobin is carrying. That's expressed as a percentage. So if your SaO2 is 90%, this means generally that the 90% of the hemoglobin actually have oxygen bound to them. The oxyhemoglobin dissociation curve is another very important concept that you have to remember. This is the curve that represents the oxygen delivery to the tissues, which depends on two things. One, the amount of oxygen that can be picked up in the lungs, and the ease at which the hemoglobin then gives up the oxygen when it reaches the tissues. So that's what this curve actually represents. It's very important, to pay attention to the curve, because you're going to have patients that are shifted to the left and to the right, and you're going to be wondering why their O2 sats are what they are. And this is the curve that kind of talks about that or represents that. So, blood has to travel to the lungs via the pulmonary circulation. Oxygen has to be, your lungs have to be able to take in oxygen. The oxygen then has to diffuse across that membrane, and then the hemoglobin that are there passing by those alveoli in the capillaries has to be able to take that oxygen, bind it, carry it out of the lung or the pulmonary vasculature, and then when it gets to the tissue that needs it, it needs to be able to unload it, and that's essentially what this curve represents. So the upper flat portion of the curve actually represents the loading of oxygen onto the hemoglobin. And what this demonstrates really specifically, your PaO2 is at the bottom, or your PO2, and your O2 sat is over here on the left-hand side, up and down. And so what this basically shows you is that with a large change in PaO2, there's little change in hemoglobin saturation. This is why when your PaO2 drops from 100 to 60 millimeters of mercury, your O2 sat actually only drops 7%. This is really important, right? Because that means that the hemoglobin actually remains 90% saturated, despite the fact that it just dropped, the PaO2 just dropped 40 millimeters of mercury. So from your PaO2 of 100 down to 60, your O2 sat does not really drop below 90. Very, very important, because if you have someone who's hypoxic or someone who's, in respiratory distress, and you say, well, their O2 sat's 91%, well, their PaO2 can be 70, can be 90, can even be 65. So they can actually be hypoxic at the tissue level, but have an adequate O2 sat. Very, very important when you're talking about patients. So, we're so quick to get an O2 sat on patients, but it shouldn't really be the number one factor that we're using to determine whether our patients are hypoxic or not. There are better things that we could be using. And the steeper portion of the curve here, the lower portion of the curve, represents the unloading of oxygen at the tissues. And what this lower portion of the curve demonstrates is that with a large change in SaO2, now your O2 sat hits 70, 60, 50, 40%, you're going to get a small change in PaO2. So as O2 is unloaded to the tissues and the PaO2 drops, what you're ensuring is that there's adequate oxygen for the tissue. So the SaO2 drops, as the SaO2 drops or the SAT drops to less than 90%, the patient's becoming more hypoxic at the tissue level. The patient can shift to the left or the right of the curve, and you may hear this terminology, oh, I think this patient is shifted to the right on the oxyhemoglobin curve. A left shift represents the hemoglobin's increased affinity for oxygen, so oxygen is going to be loaded in the lungs more easily, but not unloaded at the tissue level. And so what happens is the hemoglobin actually there has an increased affinity for oxygen, and it holds onto the oxygen, so you're going to have a higher SaO2 for any given PaO2. So although your SaO2 is high, the tissues are actually starving because the hemoglobin, which the O2 sat measures, is really holding onto that O2. You see that in times when there's hypothermia or the patient is alkalotic. You also see this in times of septic shock and carbon monoxide poisoning. When we talk about septic shock, we're going to take a look at the fact that our patients are actually truly tissue hypoxic, which is why your O2 sat is really never something that you can really rely on. A right shift represents the hemoglobin's decreased affinity for oxygen, which means that the O2 is less easily loaded in the lungs, generally because there's probably some chronic lung disease, but it's unloaded easier at the tissue level. So you have a lower SaO2 for any given PaO2. You see that in times of acidosis, you see that in hyperthermia, you also see that in chronic hypoxemia from chronic lung disease. This is why COPDers can walk around with a SAT of 85% and we're not freaked out by it, because we know their PaO2 is actually higher because they're shifted to the right on that curve. We can evaluate oxygen based on two things. One is pulse oximetry. The other is arterial blood gas. The arterial blood gas is, of course, more, is a better test, but it's more invasive than a pulse ox. ABGs are actually measured to determine true oxygenation status of the patient, but also their acid-base balance. So we obtain blood arterial and we measure their PaO2, their PCO2, the pH of the blood, their bicarb, and it helps us determine whether there's, a metabolic problem or a problem with a respiratory, or if it's a respiratory problem. You can also get an O2 sat or a saturation from an ABG. This is actually a calculated O2 sat, and so actually it's a little more accurate than just a pulse oximeter. And so you should review ABGs in your textbook. Pulse oximetry is just a non-invasive monitoring use of a probe. We can put it on a finger, on an ear, bridge it to the nose. So you can use forehead probes as well. And all it does is use wavelengths of light that are infrared, and basically well-oxygenated blood absorbs light differently than deoxygenated blood does. So the oximeter determines the amount of light that's absorbed, right in the vascular bed of the location that we're taking the pulse ox only, not the entire system. And it calculates a saturation based on that. So we do have to be mindful of pulse oximetry and the things that alter those readings. Motion is one, low perfusion states is another. Patients who are anemic, their O2 sat is not going to be accurate. Patients who have cold extremities, also not going to be accurate. Bright fluorescent lights in the room can alter your O2 sat, and also patients who are wearing nail polish and thick acrylic nails will have an O2 sat that's probably not accurate. the one thing I want you to remember from this slide is the first sign of hypoxia is restlessness. As your SpO2 drops from 100 to 80% to 60%, you wind up with a decrease, obviously, in level of consciousness and brain function. So as hypoxia increases, the patient will get more and more dysfunction, brain dysfunction. So as your SAT decreases, patients get more confused, they start to get combative, they start to get lethargic, and then they get comatose. So obviously, lethargy is a later sign of hypoxia, but do remember that the first sign of hypoxia is really restlessness. Again, it makes sense because the brain is very sensitive to oxygen. The brain is the first thing that gets fed after the left ventricle pumps out that large amount of cardiac output. Your, carotid arteries are right there. So north the blood goes, brain gets fed first. So if you are hypoxic, the brain is the first organ to sense that, and restlessness is in fact the first sign. So we'll look at a few disease processes really quickly, just so that you remember the patho behind some of the things that we're going to talk about. COPD is one. We'll talk about respiratory failure in COPD specifically. Why does respiratory failure occur with COPD? Well, COPD has two variables. COPD is really an umbrella term, and it either is a function of chronic bronchitis, so patients can have a chronic bronchitis picture. They can also have an emphysema picture, or they can have a mixed bronchitis and emphysema as well. Chronic bronchitis is really characterized by inflammation and thickening and narrowing of the bronchial airway. It's marked by the presence of very thick mucus. This is why the patient with chronic bronchitis usually manifests as a very dry, as a wet chronic cough with a lot of sputum production. The mucosal lining of the bronchial airway becomes inflamed. Generally, it's because it's irritated by some substance, mostly cigarette smoking. And so what happens is you get an inflammatory response, and if you remember your inflammatory cells, like your lymphocytes and your macrophages, they actually destroy the submucosal lining, and because they destroy the mucosal lining of the bronchial airways, you get mucus cell or goblet cell hyperplasia, and that actually leads to increased mucus production. So the chronic bronchitis patient really is marked by chronic inflammation, mucus production because of this hyperplastic goblet cells, and then you wind up with long-term fibrosis of that airway. So the airway becomes more narrow over time, and it becomes harder and harder to breathe over time, which is why dyspnea in COPD is progressive. Emphysema, on the other hand, is characterized also by chronic inflammation in the airways, but also you get the accompanying destruction of the lung parenchyma, which is the actual alveoli or the gas exchanging surface of the alveoli, and you get destruction of the pulmonary vasculature as well. Again, inhalation of the noxious stimuli. Cigarette smoking is going to be the #1 cause of COPD. You have that same inflammatory process, but this time, not only do you have the significant mucus production in the bronchial airways, but you also have destruction of the small bronchi and bronchioles down towards the alveoli. The lung tissue itself, from the same inflammatory mediators, gets destroyed, and you wind up with overdistended alveoli at the end. So the overdistended alveoli look something like an overinflated balloon. This is what's called a bleb, and so there's a loss of elastin as the supporting wall structures get destroyed. Air goes into the lungs easily, but it gets trapped there, and that because of this decrease in elastic recoil, remember we said recoil is important because that's what forces air out. Well, there's no elastic recoil left, or the ability of the lungs to recoil is no longer there, so air gets trapped. And this is what creates the barrel-chested appearance of most patients with COPD. It increases the AP diameter of the chest wall from these overdistended alveoli. And then eventually you get destruction of not only the alveoli itself, but also of the pulmonary vessels. So you can see here the lung just completely destroyed. There just is no lung tissue to actually aerate anymore. So Both bronchitis and COPD lead to a significant ventilation perfusion mismatch. A VQ mismatch is something we'll talk about in class this week. And you wind up with hypercapnia, or CO2 retention, and you wind up with a respiratory acidosis. So some symptoms that you'll see in your patient, of course, is going to be dyspnea. These patients will frequently have a chronic cough and a lot of sputum production. Dyspnea is often progressive. PFTs, or your pulmonary function tests, are going to be important because they're going to show an increased lung volume. Again, in your emphysematous patient, you have this overdistended airway, so you have an increase in lung volume. That does not mean, though, that you have an increase in oxygenation. Usually, you're going to see a normal pH, but you're going to see hypoxia on your ABG, and you're going to see most likely an increased normal or increased PaCO2. Chest tightness usually follows activities. Patients will frequently complain of tachycardia as well, or complain of chest tightness. And you might hear wheezing on these patients when you have bronchoconstriction, but you'll hear breath sounds that are usually dim because the alveoli just are already over-distended. There's no air movement in and out of them. You may see or hear the term pink puffer or blue bloater, and so basically the pink puffer is your emphysema patient. These patients tend to have, again, the increased AP diameter from the emphysema. You're going to see they're usually more pink in nature. That's why they're considered, they have this pink complexion. They have usually less hypoxemia than the blue bloater. They're working very hard to breathe. They're using a lot of their sternocleidomastoid massoid muscles and a lot of their accessory muscles. So the increased metabolic demand of the patient is much higher in the pink puffer. So they tend to be a little bit underweight. And you might see muscle wasting as well. The blue bloater is more of the chronic bronchitis person. You're going to see the excessive mucus production. You're going to have real airway obstruction from the chronic bronchitis. These patients have a much bigger VQ mismatch because they have the inability to really take in the breath. You're going to see an increased CO2 retention in the blue bloater as well because of the increasing obstruction. Their residual lung volume gradually increases as well, which is what they're considered to be the bloating part. They become very hypoxemic, very fat, they become hypoxemic and sort of cyanotic, and so they have a little bit more of the bluish tint to their skin. These are the patients that exhibit the pursed lip breathing that you're probably used to hearing about or used to seeing. That's more of the chronic bronchitis patient. Respiratory failure in asthma, just really briefly, asthma also an obstructive pulmonary disease. Chronic, again, you have chronic inflammation of the airways. These are the large airways. And it's usually because of exposure to some kind of allergen or irritant that sort of initiates the inflammatory response. And what happens is, again, you have those mast cells and things in the basement membrane of the bronchial airway. Those mast cells degranulate because of the allergic response that you get, and so they release histamine and other inflammatory mediators, and so these mediators actually result in the airway being infiltrated by a lot of inflammatory cells, and those inflammatory cells result in a lot of vascular congestion, a lot of edema. The production of very thick mucus is usually something that the asthma patient has. You get muscle spasm and thickening of the airway wall, and because this is a repeated process, asthma is a chronic disease that's marked by exacerbations and times when our asthma is under control, and so because of this chronic inflammation, you wind up with remodeling of the airway. The bronchial smooth muscle actually, hypertrophies, and collagen actually gets deposited in the airway walls. And so you get this cycle, again, of just, inflammation, damage to the airway, prolonged repair, fibrosis. So over time, the remodeling airway, it becomes just harder and harder. It's just more progressive. It'll become harder and harder to breathe over time. Symptoms that you see in your patient, very classic, are dyspnea. Patients, especially during an exacerbation, will tell you that they can't breathe. You will hear wheezing, and that usually comes from the airway. Prolonged expiration is very typical in asthma patients. This produces the classic feelings of suffocation that patients with an asthma attack will tell you they're having. It's very, very scary to patients. So normal inspiratory-expiratory ratio is 1 to 2, but in asthma it's 1 to 3 or 1 to 4. Those bronchioles constrict during expiration, but because of bronchospasm and edema and mucus production, they're narrower than normal, so it just takes longer for air to move out of the bronchioles. And what happens is air gets trapped in our alveoli. And that's what causes the characteristic wheezing that you hear. First you have expiratory wheezing, and then you have inspiratory-expiratory wheezing as the inflammation gets worse. No wheezing at the time of an asthma exacerbation is actually an ominous sign. Cough sometimes can be accompanied by asthma attacks as well. People, again, often feel like they're suffocating because they cannot move air out of their lungs. They frequently will sit in that tripod position using all their accessory muscles to breathe, so do look for that. The harder it is to breathe, the more anxious the person gets. And so, again, signs of hypoxia that you'll see early on in patients with asthma, acute asthma exacerbations, are restlessness. They become, inappropriate behavior, tachycardia, anxiety. They're tachypnic. Usually their respiratory rates are very high, usually 30 or more. They may or may not be able to speak. So the ability to phonate is very important when you're talking about asthma. There's a difference between the patient who can speak in full sentences and the patient who can only say simple words. So it's just a sign that maybe their asthma exacerbation is worse if they cannot really speak. Patients usually hyperventilate during an asthma attack. So the patient will be, hypoxic with a decreased CO2 because they're hyperventilating and blowing that CO2 off. But as the airflow limitation worsens, you get more air trapping. The patient actually, the CO2 will normalize and the patient will tire, and that will produce a respiratory acidosis, and a respiratory acidosis is actually a sign of impending respiratory failure. So it's really important that the nurse working in an acute setting recognize the signs of impending respiratory failure in the asthma patient. Okay. Respiratory failure in pneumonia is really due to some insult or organism that sort of invades the lungs. Pneumonia creates a very typical inflammatory response. Usually healthy people, we don't really get pneumonia because we're strong enough to fight it. But when we're immunocompromised in some way, or we have, lung disease to begin with, it's just much harder to overcome that invasion of the organism. So you get an immune response, so you get a lot of signs of clinical illness with that. You feel crummy, you may have a fever, you're fatigued, chills, body aches. Those are all signs of pneumonia. Pneumonia can be caused by bacteria, viruses, fungus. We can inhale chemicals that can be toxic, such as smoke or dust. We can aspirate food or vomit or fluid into our lungs and cause, an aspiration pneumonia. But no matter what the cause, there's still the same inflammatory response inside the pulmonary vasculature. Symptoms of pneumonia are, cough. Usually cough is productive. If it's bacterial in nature, you may have a green sputum production. Dyspnea, tachypnea, patients will frequently complain of pleuritic chest pain, fever, chills, aches, just sort of that sort of all over systemic inflammatory disease. Those symptoms are pretty common in pneumonia patients. The older patient, though, may not mount a fever, so do be mindful that the first sign of pneumonia in a patient who's elderly might actually be confusion, and that's due to hypoxia or falls. So patients who are falling frequently, one of the signs is, aside from looking for a UTI, we always look for pneumonia. Again, it's usually they fall because they're weak or hypoxic. They may also manifest a decreased appetite, and that might be one of the signs of pneumonia as well. You're usually tachycardic because you're fighting an infection. Your APG may show hypoxia and hypocapnia. Your CBC might show a high white cell count, so you're going to look for that. All right. And pulmonary embolism. Lastly, an embolism is really just a thrombus. Embolus is a clot. Essentially, it usually travels from a different location in the body. Most common a pulmonary embolism comes from a DVT. So as a nurse, you're going to be very comfortable with DVT prophylaxis because that is a CMS requirement. DVT and PE following hip replacement and total knee replacement are now considered never events. We are to so if our patients get them, they're not reimbursable by Medicare and Medicaid because they're avoidable. We should be recognizing patients who are at risk for pulmonary embolism, usually due to something called Virchow's triad. So these three things we're always looking for: venous stasis or reduction in blood flow, so our patients who are on bed rest following surgery. They have altered coagulability of the blood because they've had surgery, and they have blood vessel wall damage because we've cut through the vessels when we did surgery. So those three things kind of put together increase the patient's risk of a DVT, which is why we usually screen patients daily and provide DVT prophylaxis in our patients who are at risk for PE. So you can have PE is usually acute. You can also have chronic PE, but the respiratory failure comes from the acute PE. You can have massive, submassive, or non-massive pulmonary embolism. So why does pulmonary embolism actually cause respiratory failure? Well, you get a blood clot that lodges in the pulmonary vasculature, and basically you get an impedance of forward blood flow, right? You get a clot in the pulmonary system, and so blood comes from the right ventricle and cannot actually get into the lungs because of the clot. So the pulmonary system initially will compensate in order to oxygenate. It's kind of trained to do this. When we exercise, our pulmonary blood flow increases, and so lungs have to be able to handle this. So this is why many times patients with a large PE do not die right away. So beyond the clot, though, there's no blood flow to the alveoli, and this actually increases what's called a dead space, and so the patient winds up with a VQ mismatch. We can take air into the alveoli, but there's no hemoglobin in the capillary flowing by the alveoli, so you wind up with a ventilation-perfusion mismatch. So you're unable to perfuse an oxygenated alveoli, and so therefore gas exchange can't occur. So blood that does wind up coming out, if any, is unoxygenated on the other side of the lungs. So the body thinks that something's happening at the site of the actual mechanical obstruction. The only thing it knows to do to try and fix the problem is trigger an inflammatory response. You get the same inflammatory mediators, and they actually cause constriction of the bronchi and the surrounding blood vessels just because of the inflammation. And they create airflow limitations that actually make the work of breathing worse or harder. So what happens is, as the work of breathing increases, the alveoli begin to shrink from the hypoxia, and now you have a worsening VQ mismatch, and now you have shifting away, you have ventilation that's shifted away from the collapsing alveoli, and so your patient becomes more and more hypoxic. The process is going to lead to pulmonary hypertension, and as there's an increase in blood flow, the right ventricle actually tries to hypertrophy from the increased work. So the right ventricle has to push really hard against the increasing pulmonary pressure because of this clot. And so it grows in size in order to try and do this. So when you hear the term right ventricular strain on echocardiogram when you're looking at a submassive PE, because what you see is a very large right ventricle and a very small left ventricle. And the reason is because the right ventricle pushes the septal wall to the left. That puts pressure on the left ventricle. Your left ventricle gets smaller or compresses, left ventricular filling decreases, and you end up with a loss of cardiac output. So patients will develop biventricular failure, and that biventricular heart failure is going to lead to cardiogenic shock. So your patient with the massive PE ends up with cardiopulmonary compromise because of it. Prompt treatment is really needed in order to overcome this because the hypoxia is going to be profound. So the patient who's relatively healthy before the big PE, the mortality for that patient is slightly less, but if you have underlying heart disease and lung disease already, you may not be able to survive the pulmonary embolism. So that's just a basic review. Just gives you sort of a starting point so that when we have class this week, we'll be able to talk a lot about the nursing interventions for respiratory failure. So I hope this was helpful.